Today's lecture is going to be on somatic symptom disorders. Objectives are going to look at psychosomatic illnesses, describe what they are and identify central features, look at etiologic theories, and then discuss the characteristics and dynamics of specific somatic symptom illnesses. In addition to that, we're going to distinguish those fictitious disorders and malingering disorders from that somatic system, apply the nursing process, provide education, and evaluate our feelings, beliefs, and attitude regarding the clients with somatic disorders. With somatic disorders, these are very complex because these are manifestations of psychological distress that the patient feels is actually physical. It results in functional changes, but there are no organic causes. No, they're not intentionally caused. They're likely the results of ineffective stress management that results from anxiety. In other individuals, it could be related to childhood sexual abuse, and that creates that trigger for your patient. Just remember that somatization is the physical expression of that personal problem or that internalization and expressions of stress through physical symptoms. An example of this is a woman who quits her job reporting chronic fatigue syndrome rather than recognizing that she's actually emotionally stressed from the harassment of her coworkers. The onset of somatic disorder usually happens before the age of 30 amongst women who are limited, whether it be related to economic, education, cultural biases, or limited access to mental health services. Risk factors relate to it running in their family due to learned coping mechanisms and a deviation away from that, but also childhood neglect or sexual trauma exposures. Depression and anxiety are comorbidities that go along with this, and other medical problems. The treatment goal is just to replace the maladaptive behavior or the attention-seeking behavior with adaptive positive behaviors through conversation, and to find a way to not allow what they feel is going on with them to consume their ability to live a life successfully. There are different types of disorders. So you have somatization disorder, which is about physical complaints. You have conversion disorder, where they actually lose a functioning that go along with that. You have hypochondriasis, which is a fear or belief that there is an illness. You have body dysmorphic disorder, where the person has a normal appearance but is concerned and believe that they have a defect. Pain disorder, which is a psychological factor that plays a role in not only that onset, but that severity and the maintenance of that pain. And fictitious disorder, and that comes from a need to have attention. A lot of this results from, again, that internalization of their emotions. They're going to have stress, they're going to have anxiety, but they're also going to have frustration. The primary gain for them or the patient is the benefit of being sick. Because they believe it and they can convince themselves of it, that anxiety begins to be relieved. There's no conflict or distress, and that's where that maladaptation comes from. As far as the internal and personal benefit from others, they get the attention from their family. It's a comfort measure for them, and there are personal benefits that come, especially when they feel or that their family members believe that they are truly sick. Other characteristics include multiple yet vague physical complaints, gratification of dependency needs that need to have that dependency of others. It also may include that personal attention, release from unpleasant situations or responsibility, especially going back to that example that we had earlier with the employment. It can be organic symptoms that just help reduce their anxiety and provides the nurse a little bit more information as to what that conflict may be with them. Assessment-wise, we're going to review their symptoms. We're going to, and systems. We're also going to check their pain, which is the most common concern that they have, which makes it also difficult because we treat pain as it being real for that individual. We're going to look at physical functioning. looking at this, just remembering and reminding ourselves that to that patient, the symptoms are very real to them. So we don't want to trivialize them. We don't want to challenge their realness either. The symptoms relates to more just helping them develop coping mechanisms as it relates to that anxiety. That illness is more acceptable for them than it would be if we were to tell them it's anxiety, because that's not as real and tangible as them actually having a physical illness, which is why it's hard to overcome that thought process with them. There is an increased risk for overdose. They're going to seek care from multiple providers. And again, as we mentioned in earlier slides, comorbidities that go along with that include depression and chronic anxiety. So one of the things that we can do to assist patients who are suffering from somatic disorders can be psychopharmacologic interventions, but understand that with that, it takes about 6 weeks to have the desired effect from that medication. Medications commonly used are tricyclics, SSRIs for anxiety and mood stabilizing, your anti-anxiety medications, and one of the things we have to look at is their side effects and making sure that there are no drug-to-drug interactions, and then teaching them accordingly. Know that your patient may seek out prescriptions for benzodiazepine, but understanding that this is very addictive and requires weaning, they could go into withdrawal symptoms. And so if we are using this medication for them, we need to communicate that this is just a short-term use only. They will not be going home with that prescription. The biggest thing about benzodiazepines is that they don't interact well with alcohol or opioids. A better choice of medication really would be to give them a non-benzo to manage that anxiety. One of the examples is Buspar. That medication has no tolerance or addiction issues and no withdrawal issues. So going back to conversion disorder, which is not going back to, but talking about that, they have symptoms but no signs. So they have neurological symptoms, sensory problems, but they have no physical connection to some type of medical diagnosis. The symptoms follows that perceived conception that they have of a problem, and it can possibly be from a neurological change that happens in their brain, or again a childhood trauma. And how we manage that is acknowledging the symptoms, developing a trusting therapeutic relationship with them, and then helping them to develop problem-solving skills. The younger they are, though, when they experience the stress, the more of an impact it has on their coping skills and their ability to trust and problem solve. So you really have to be adamant and purposeful in your assistance that you provide for them. There are going to be sensory symptoms that include numbness, blindness, and deafness, motor symptoms related to paralysis, tremors, and mutism. There can be visceral symptoms like urinary retention, headaches, difficulty breathing, and these are difficult to diagnose. Also just looking at their response through behavior. With conversion disorder, your patient displays a little or no concern about the actual symptoms or the fact that it can be debilitating for them, and this is called the labile indifference. You still have to be attentive to their safety issues that this disorder can cause. However, the dysfunction that goes along with this really prevents them from really acting on unacceptable impulses or engaging in an activity that's unpleasant. However, you still need to monitor them. And then the diagnosis and treatment can only begin after it has been ruled out that there are no physical causes. With body dysmorphic disorder, they do focus on real but slight, very small or imagined defects that they may see in their appearance that can cause them distress and can impair their social functioning. Usually the onset happens around the time that they're adolescent and can continue into their adulthood. There's no one theory that really explains it. There are some studies that say that bullying or having unrealistic cultural expectations, dispositions, sometimes they say can be passed on from throughout the generation. Maybe it was a parent or a sister or familiar individual who may have passed this down or this thought process. Also, cultural expectations can also have an influence. With treatment, we're going to give them SSRIs and antidepressants for the anxiety and depression. We're going to make sure that we assess them for suicidal ideations, maintain a therapeutic relationship with them, support positive physical aspects about themselves, help them see more than just what their focus is, have them have a respect for preoccupation, but don't challenge their beliefs. Give them something else to do and to focus that attention on, but making sure that we keep them safe. With illness anxiety disorders like hypochondriasis, this is an involuntary exaggeration of what they perceive as a physical health issue with no organic cause. They misinterpret physical issues. They move towards ruling out and trying to determine if they have this. They presume that they do. They begin to have fear over it. They begin to seek out information, and they actually go through this pathway of this mental but also emotional, I'll call it stress, over something that has not yet been validated. It is not the same as your patient who wants to malinger because they feel as though they have a fake illness or don't want to take on the responsibilities that they have. This is different from that. With somatic pain, they have some complex sensory and emotional experiences that make them feel as though that or intensify the pain they have, being more than what it is, and again, without a physical organic cause. It can be influenced by their behavior. It could be cognitive along with psychological. But when it comes to acute pain, they're not going to respond well even to pain medication, and this syndrome can last for with this chronic pain for about a minimum of about 6 months, and can be exacerbated when they have stress or conflict. With these disorders, the biggest thing is you have patients who truly believe within their minds that there is something wrong with them, and so they seek out assistance, whether it be through multiple doctors, multiple admissions within a hospital, but often sometimes you'll see multiple admissions to a psych unit, and a lot of the times they have this thought process that they're not being helped, although their problem is real to them. And so one of the things we want to make sure that we do is that we don't try to convince them that what they're feeling is wrong. One of the things we do need to do, though, is be mindful of their safety, because not going a long overdue time feeling like no one's taking you seriously or fixing the situation can put that person at a greater risk of suicide. It can, when it comes to suicide, suicidal ideations, especially if pain is their issue and if someone's not aware of it, then they can use the medication that they receive. So that's why it's always important, not only just the physical assessment that we're supposed to do, but also when we got a patient that's complaining of pain, but no matter what medication we give them, it's not being resolved, then we need to think that it may be a somatic disorder. Not only do they come with chronic pain or believe that they have chronic pain, but other comorbidities that go along with that include substance abuse, pain medications, depression, and anxiety. Cultural implications. Their experiences and expressions in treatment of pain are subject based on what is their norms, and sometimes we have to make sure that we engage in self-reflection so that when we're treating our patients that we don't use our own biases to interfere with how we care for them. To think about our patients and their cultural backgrounds, what is common for them, how they like to be treated, and then make sure that we're supporting them correctly. Fictitious disorders come with characteristics of things that these individuals will engage in that include intentional injury, to receive attention from healthcare workers. Usually this is common in females at the age of 20. The motivation is to develop some type of dependent relationship. And I go back to Maslow's hierarchy, where I feel like sometimes maybe for these individuals it's about not having their love and belonging met, And so when they do get that attention and they haven't had it, that is an exhilarating feeling. It causes euphoria, and so they will do anything they can to keep that. With that, fictitious disorders, those that can result in them either directing their energy towards themselves or by proxy. So think about Munchausen. So if it's not directed at themselves, then in some cases by proxy, it can be the parent or caregiver who may be bringing harm to an individual who can't speak for themselves. And majority of the time that it happens more with children, but sometimes it can happen with the elderly as well. The history of fictitious disorders come from what they believe to be severe sexual or marital distress. They could have been abused as a child, only get attention when they were sick, or were rejected as an adult. Comorbidities that go along with that include mood disorders, personality disorders, and substance abuse disorders. And make sure that I put this on the record just to say that when it comes to the etiology, these are just some of information that has been revealed, but it's not pertinent to every individual.